Cornebacterium is a club-shaped bacteria. It is gram-positive and Cornebacterium is non-capsulated and non-sporing and non-motile rods are present. Cornebacterium diphtheriae or club Slophla bacillus. It will show two additional features: Chinese letter or cuneiform arrangement in smear, which is V or L shape. Due to bacterial cells divide and daughter cells tend to lie at acute angles to each other. So this type of cell division is called a snapping type of division. Metachromatic granules are present at end or poles of bacilli, which is known as polar bodies or Babes anus bodies or vaulting granules. It is a storage granules and it composed of polymetaphosphates, and it is better stained with special stains such as Albert's, Neisser's and Ponder's stain. Granules are well developed on enriched media such as blood agar or Loeffler's serum slope. Vaultin granules can be possessed by Cornebacterium cirrhosis, Gardnerella vaginalis, Spirillum, few Mycobacterium species, Enterobacter aerugine, and few yeast. Next one is the virulence factor, diphtheria toxin. Mechanism of action. Diphtheria toxin is a primary virulence factor which is responsible for diphtheria. So the diphtheria toxin has two fragments. One is fragment A and the other one is the fragment B. Fragment A is the active unit and fragment B is the binding unit. So fragment B will bind to the host cell receptor such as epidermal growth factors, and it will help in entry of fragment A. Fragment A is internalized into host cell, then it will causes adenosine diphosphate ribosylation of elongation factor 2, then it will lead to incubation of elongation factor 2 that lead to irreversible inhibition of translation step of protein synthesis that lead to cell death. Mechanism of diphtheria toxin is similar to exotoxin A or Pseudomonas. Toxin production is dependent on phage coder. Diphtheria toxin is coded by beta carniophage carrying tox gene. Iron concentration. The toxic production depends upon iron concentration. Only 0.1 milligram per liter is needed. Higher levels of iron inhibit toxin synthesis by regulating diphtheria toxin repressor gene in the bacterial chromosome. Diphtheria toxin repressor gene. It is an iron-dependent negative regulator of diphtheria toxin production and iron uptake in Cornebacterium diphtheria. Next one is the biotypes of Cornebacterium diphtheria. Among the three biotypes of Cornebacterium diphtheria, all strains of gravis, 95 to 90% of strains of intermediates, and 80 to 85% of mighty strains are toxigenic. However, toxin produced by different biotypes of antigen similar. Other species such as diphtheria toxin is produced by Cornebacterium ulcerans and Cornebacterium pseudotuberculosis. Toxoid is used for vaccination. Diphtheria toxin is antigenic and antitoxins are protective in nature, so it is virulent, so it cannot be given directly for vaccination. Toxin is converted to toxoid, which is used for vaccination. Toxoid formation is promoted mainly by formalin, acidic pH, and prolonged storage. The main important strain used is Park William H strain of Cornebacterium diphtheriae. For it is used for the preparation of vaccine. Loeffler flocculating unit. Diphtheria toxin is expressed as Loeffler's flocculating unit. One Loeffler flocculate unit means amount of toxin which will flocculate rapidly with 1 unit of antitoxin. Next one is the pathogenicity and clinical manifestation. Diphtheria is always toxemia, but it is never a bacteremia. Bacilli of diphtheria is always non-invasive. It will present only at the local site, means mainly the diphtheria will present at the pharynx. In pharynx, it will secrete toxins. Then from there, through blood spread, it will spread to various organs. It is toxin which is responsible for all type of manifestation. Mainly, it will include local respiratory and systemic complications. First one is the respiratory diphtheria. It is the most common form of diphtheria. Tonsil and pharynx facial diphtheria is the most common site, followed by nose, larynx, and rarely non-respiratory mucosa such as conjunctiva or vagina is seen. Incubation period of respiratory diphtheria is about 3 to 4 days. Facial diphtheria toxin will elicit an inflammatory response, then it will lead to necrosis of epithelium and exudate formation will be there. Then that will lead to formation of pseudomembrane. Pseudomembrane is tough, leathery, grayish white coat, and it composed of inner band of fibrin surrounded by neutrophils, RBCs, and bacteria. Pseudomembrane is so named because it is adherent to mucosal base. On removal, bleeding will be there, which is same like the candida. Extension of pseudomembrane will occur in severe cases. Mainly, it will extend into larynx and medium-sized bronchial airways that will lead to severe airway obstruction that lead to respiratory difficulty. In such case, immediate tracheostomy is needed. Next one, bull neck appearance is seen. It is characterized by massive tonsillar swelling and neck edema is seen. Next one is the cutaneous diphtheria. It is mainly occurs in the skin. It is characterized by punched out ulcerative lesions in which necrosis will be there, but only in rare case only pseudomembrane formation will be there. Cutaneous diphtheria is mainly due to the diphtheria. It is toxin, not toxin mediated. Skin lesion is also caused by non-toxic genic strains. There is an increasing trend of cutaneous diphtheria nowadays due to vaccinated children because antitoxins present in vaccinated people cannot prevent the cutaneous diphtheria. Some systemic complications will occur, mainly neurological manifestations. Cranial nerve involvement will be there, peripheral neuropathy, ciliary paralysis, and myocarditis are late toxic manifestation. It will occur 1 week after infection of Corneabacterium diphtheria. Next one is the laboratory diagnosis of Corneabacterium diphtheria. The diagnosis is based on signs and symptoms plus laboratory confirmation. Because of respiratory obstruction and specific treatment should be started earlier without waiting for laboratory reports. Laboratory diagnosis is only for confirmation, initiating the control measures. Epidemiological purpose, laboratory diagnosis consists of isolation of bacilli and toxin demonstration. Isolation of diphtheria bacilli specimen throat sub 1 or 2 times it is collected containing fibrinates, exudates, and portion of membrane should be there. Under direct smear microscopy, gram stain, Corneabacterium diphtheria appears as irregularly stained, club-shaped, gram-positive bacilli arranged in Chinese letter of cuneiform arrangement, which is V or L shape. It is difficult to differentiate them from other commensal corniform found in the respiratory tract. Aiapget stain is more specific for Corneabacterium diphtheria. In Aiapget stain, it will appear as green bacilli with bluish-black metachromatic granules. Next one is the culture media. The culture media used for enriched medium such as low flush serum slope. The advantage of enriched medium is it will detect the growth earlier within 6 to 8 hours. It is the best medium for metachromatic granules production. The disadvantage of enriched medium is if incubated beyond 6 to 8 hours, other commensals will also provide the growth. Next one is the selective medium such as potassium tellurate agar and tensile medium. The advantage of potassium tellurate agar and tensile medium is in which the throat commensals are incubated. It is the best media for isolation of Corneabacterium diphtheria from cases as well as carriers. The disadvantages of potassium tellurate agar and tensile medium is black colonies will appear only after 48 hours of incubation. Next one is the biochemical identification. His serum sugar media, Cornybacterium diphtheria will ferment glucose and maltose by all biotypes. Only starch is fermented by only gravis biotypes. Next one is the pyrazine amidase test. It is negative for Cornybacterium diphtherium, Cornybacterium ulcerans, and Cornybacterium pseudotuberculosis. Urase test is negative for Cornybacterium diphtheriae, but in Cornybacterium ulcerans and Cornybacterium pseudotuberculosis, urase test is positive. Cornybacterium test is catalase positive, but oxidase negative, and it is non-motile. Toxin demonstration. The pathogenesis is mainly due to diphtheria toxin. Isolation of bacilli does not complete the diagnosis. Toxin demonstration should be needed, which can be of two types, in vivo and in vitro. In vivo test, guinea pig inoculation by subcutaneous test and intracutaneous inoculation is done. In vitro test, LX gel precipitation test, detection of toxin by PCR, detection of diphtheria toxin by ELISA or immunochromatographic test, cytotoxicity produced on cell lines. Next one is the typing of Cornybacterium diphtheria, biotyping, MC Lior's classification. It can be typed into four biotypes, gravis, intermedius, mitis, and belfandi, based on various properties. Biotype belfandi is nitrate negative. Other methods, serotyping, bacteriophage typing, bacteriocin typing, and molecular typing method such as pulse field gel electrophoresis method is used. Next one is the Cornybacterium diphtheria biotypes. Gravis, the morphology, it has short and no granules. Intermediate, long bad pure granules is present. In mitis, long curved prominent granules is present. Under colonies of PT, potassium tellurate agar media, daisy head appearance is seen in gravis biotype, and frog's egg colony is seen in intermediate biotype. In post mitis media, post egg colony is seen. Under starch fermentation test, gravis is positive, intermediate is negative, mitis is negative. Toxigenic strains for gravis is 100%, intermediates 95 to 99%, mitis 80 to 85%. Virulence of gravis is severe, intermediates is moderate, mitis is mild. The occurrence of gravis is epidemic and intermediates is epidemic and mitis is endemic. The complications of gravis is paralytic and hemorrhagic is seen, and in intermediates hemorrhagic complications is seen. In mitis obstructive complication is seen. Hemolysis of gravis is variable. In intermediates it is non-hemolytic. In mitis it is hemolytic. Next one is the epidemiology. Diphtheria is the endemic disease. It is known from the ancient time. However, there is a declining trend of diphtheria case in most developed as well as few developing countries, including India, due to widespread of vaccination coverage. Source of infection, carriers 95% are the more common source of infection than cases. In cases, only 5% is seen. Carriers may be temporary, it will persist only for a month, and chronic, it will persist for a year. Nasal carriers are dangerous due to frequent shedding. Then throat carriers. Incidence of carrier rate varies from 0.1 to 5%. Transmission is through the aerosol route or rarely by the contact with infected skin lesions. The reservoir of Corneabacterium diphtheria is mainly the humans are the only reservoir. Age mainly the Corneabacterium diphtheria is seen in 1 to 5 years with widespread immunization. A shift in age has been observed from preschool to school age. Newborns are usually protected due to maternal antibodies. Prophylaxis vaccination. Active immunization is done by diphtheria toxoid. It will induce the antitoxic production in the body. Protective titration of antitoxin greater than 0.1 unit per milliliter. Had immunity greater than 70% is required to prevent epidemic spread of diphtheria. Vaccine is not effective for prevention of cutaneous diphtheria. Elimination of carrier stage. Types of vaccine. Single vaccine and combined vaccine is used. Single vaccine, it is a diphtheria toxoid, alum or formal precipitated. Combined vaccine DPT, it contains diphtheria toxoid, pertussis whole cell, TT, tetanus toxoid. DAPT contains DT, TT and acellular pertussis. DT contains DT and TT. DT contains adult dose diphtheria toxoid and TT. DPT vaccine is the preparational choice for vaccinating mainly in the infants because infants can be immunized against three important childhood diseases such as diphtheria, tetanus, and pertussis by single injection. So, DPT is preferred mainly for the infants. Pertussis is component, it acts as adjuvant and increases immunogenicity of DT and TT. There are two types of DPT. One is plain formal toxoid or other one is adsorbed. Plain formal toxoid, it is otherwise known as fluid toxoid. It is prepared by incubating toxin with formalin. Adsorbed, it is otherwise known as alum adsorbed. It acts as adjuvant and it will increases the immunogenicity of toxoid. Next one is the administration of DPT schedule under National Immunization Schedule of India. Totally 5 doses are given. 3 doses at 6, 10 and 14 weeks of birth, followed by 2 booster doses are given at 16 to 24 months and 5 years. The site of DPT is given intramuscularly at anterior lateral aspect of thigh. Gluteal region is not preferred because the fat will inhibit the DPT absorption. Thiomesyl 0.1% is used as preservative. Storage of DPT vaccine, it should be kept at 2 to 8 degrees Celsius. If accidentally frozen, it should be discarded. One dose is given that contains 0.5 ml. Galaxo 25 low-flow-flocculating diphtheria toxoid, 5 low-flow-flocculating unit TT, 20,000 million, which is pertussis killed bacilli. Rasali 30 low-flow-flocculating unit diphtheria toxoid, 10 low-flow-flocculating unit TT, 32,000 million, which is pertussis killed bacilli. DT, it contains TT and adult dose. 2 low-flow-flocculating unit of diphtheria toxoid. DT is given to adults above 12 years. 3 doses at 0, 1 month and 1 year. Reactions following DPTs in mild cases, fever and local reaction will be there. Swelling and indurations are observed commonly. In severe cases, Bordetella pertussis is encephalogenic. It is associated with neurological manifestations. DPT is not recommended after 6 years of age. Absolute contraindication of DPT is it is hypersensitive to previous dose and it will cause various neurological disorder. Schick test, it is toxic antitoxin neutralization test. It is absolute nowadays. It was in use in long back when the vaccine was introduced initially. The test was being done on the people before starting immunization to identify susceptible individuals. Susceptible individuals used to develop erythema and induration on test term following intradermal inoculation of toxin. This vaccine was administered only to those susceptible people. Since now safer toxoid preparations are available, strict test is not performed nowadays. Next one is the non-diphtheria Corynebacterium. Cornebacterium ulcerans and Cornebacterium pseudotuberculosis can also produce diphtheria toxic and produce clinical diphtheria. It is urease positive and mainly the non-diphtheria Cornebacterium will affect the animals. Cornebacterium ulcerans, it is transmitted by cow milk. Cornebacterium pseudotuberculosis, it will affect sheep and horse. Cornebacterium minutissimum, it will cause a cutaneous lesion called erythrasma, which gives coral red color under woodland test. Cornebacterium jaicicum, it is multi-drug resistant species. It will cause opportunistic infection in human. Cornebacterium parvum, example of immunomodulator. Next one is the Bacillus. Spore forming bacilli belong to two genera. One is Bacillus and the other one is the Clostridium. Bacillus is obligate aerobes. They have non-bulging spores. Clostridium are obligate anaerobes with bulging spores. Bacillus anthracis. It is a causative agent of important zoonotic disease called anthrax. It is gained importance recently because it has ability to use as a biological weapon. Virulence factor and pathogenesis of anthrax. Pathogenesis of anthrax is due to two important virulence factors. One is anthrax toxin and the other one is the capsule. First one is the anthrax toxin. It is tripartite toxin. It consists of three fragments. One is edema factor and the other one is the protective factor and the other one is the lethal factor. Edema factor is an active fragment. It acts as adenyl cyclase and it will lead to increases heart cell cyclic adenosine monophosphate. Next one is the protective factor. It is a binding fragment that binds to host cell receptor. Next one is the lethal factor. It will cause a cell death and it will inhibit mitogen activated protein kinase pathway. These fragments are not toxic individually, but in combination, it will produce local edema and generalized shock. Toxin synthesis is controlled by plasmid. Loss of plasmid makes the strain avirulent. This was probably basis of the original anthrax vaccine prepared by Pasteur. Live attenuated spore vaccine. It is prepared by deleting the capsule gene. Next one is the anthrax capsule. Bacillus anthracis has a polypeptide capsule. It is made up of polyglutamate in contrast to polysaccharide capsule present in other capsulated bacteria. Capsule is plasmid coated. It will inhibit the complement mediated phagocytosis. Next one is the pathogenesis and clinical manifestation of anthrax. Anthrax is primarily a zoonosis, which means infection occurred from the animals. Herbivorous animals such as cattle, sheep, and less often horses and pigs are affected more commonly than the carnivorous animals. Human transmission. Human beings acquire infection by cutaneous mode, means through the skin, by spores entering through the abraded skin. It is seen in people with occupational exposure to animals, which is the most common mode. By inhalation of spores, also anthrax is affected. Ingestion of cases of animals dying of anthrax containing spores, which manifested as bloody diarrhea. Types of human anthrax, mainly three types of seen. One is cutaneous, pulmonary, and intestinal anthrax. First one is the cutaneous anthrax. It is also called as hide porter's disease. It is commonly occurs in dock workers carrying loads of hides and skins on their bare backs. The transmission of cutaneous anthrax is mainly through cutaneous exposure to spores. It will enter through the abraded skin. Cutaneous anthrax is characteristic by malignant pustule, which is painless coal black necrotic scar surrounded by non-pitting indurated edema is seen. The name anthrax, which means coal, which comes from the black color of scar, it is a non-malignant condition. Cutaneous anthrax will occur in working in occupations such as dock worker, butcher, abattoir, and farmer. More commonly, it is occur in 95% of people. The prognosis is self-limiting. Rarely, it becomes fatal if untreated. Cutaneous anthrax bioterrorism. It is rarely associated with bioterrorism. Pulmonary anthrax is also called as wool sorter's disease. It is seen in workers of wool factory due to inhalation of dust from infected wool. The transmission is by inhalation of spores. It is characteristic by hemorrhagic pneumonia. In pulmonary anthrax, mainly hemorrhagic pneumonia is seen. The bacilli will spread by lymphatics or through blood that will lead to bacteremia, hemorrhagic mediastinitis, hemorrhagic meningitis. Pulmonary anthrax is mainly seen in people working in wool factory. The occurrence is rare and the prognosis is very fatal in pulmonary anthrax. And the bioterrorism, most common form to be associated with bioterrorism. Bacillus anthracis as an agent of bioterrorism. Bacillus anthracis has been a major agent of bioterrorism and biological warfare, such as outbreaks in Władysławka in 1979 and in United States in 2001. Pulmonary anthrax is the most common form seen in bioterrorism outbreak. It occurs through inhalation of anthrax spores from contaminated animal products. Next one is the laboratory diagnosis of anthrax and anthracoid bacilli. Bacillus anthrax can be differentiated from other bacillus species, anthracoid bacilli, by the presence of following properties. Bacillus anthracis is non-motile, which means it is not movable, and Bacillus anthracis is capsulated. MC Faden reaction. Polypeptide capsule is seen as amorphous purple material. It is surrounded by blue bacilli that is stained with polychrome methylene blue. Under gram staining, a chain of bacilli arranged in bamboo stick appearance is seen in anthrax. On agar plate, medusa head appearance colony is seen, which can be seen under low power microscope. Gelatin stab appear as inverted fruit tree appearance. Solid media with penicillin. String of pearl appearance in culture smear is seen. Under blood agar, non-hemolytic colonies is seen. Selective media, blood media is used. Direct fluorescent antibody, it will detect capsular antigen. It is used for the confirmation of diagnosis during bioterrorism outbreaks. Ascolis thermoprecipitant test, it is a ring precipitation test. It is useful for detection of anthrax antigens. Spores can be demonstrated by phase contrast microscope or by special stains such as hot malachite green, ash-based method, or 0.25% sulfuric acid, or spores are acid fast. Lipid granules can be demonstrated by Sudan black bee, which means Burden's method. Prevention. Live attenuated non-capsulated spore vaccine, Stern vaccine. It is extensively used in animals. In humans, it is not used. Alum precipitated toxoid vaccine. It is prepared from protective antigen. It is safe and effective for human use. Other bacillus species, Bacillus cereus, it is a normal inhabitant of soil. It is mainly found in food items such as vegetables, milk, cereals, spices, meat, and poultry. Manifestations. Food poisoning, it will produce two types of toxin. One is diarrheal toxin and the other one is the emetic toxin, and it will causes ocular disease and it will causes severe keratitis and panophthalmitis following trauma to the eye. Other conditions it will occur, which is rare, such as systemic infections, including endocarditis, meningitis, osteomyelitis, and pneumonia. The presence of a medical device or intravenous drug use. Bacillus cereus, diarrheal type and emetic type. The incubation period of diarrheal type is 8 to 16 hours. In diarrheal type, the toxin is secreted in intestine. It is similar to Clostridium perfringens, which is an enterotoxin. It is heat labile. The food items contaminated in diarrheal type is meat, vegetables, dried beans, and cereals. The clinical feature of diarrheal type is mainly it will cause diarrhea, fever, and rarely nausea will be there. The serotype involved in diarrhea type is serotype 2, 6, 8, 9, 10, and 12. The emetic type incubation period is 1 to 5 hours. Toxin is performed toxin which is formed in diet similar to Staphylococcus aureus enterotoxin. It is heat stable. The food items contaminated in emetic type is rice, Chinese fried rice. The clinical feature of emetic type is vomiting and abdominal cramp is seen. The serotype involved in emetic type is 1, 3, and 5. Next one is the laboratory diagnosis. Bacillus cereus is motile. It is non-capsulated and non-susceptible to gamma phage. It can be isolated from fecus by using selective media such as mannitol, egg yolk, phenol red, polymyxin, and agar. Polymyxin B, egg yolk, mannitol, bromothymol blue, and agar. Next one is the Bacillus thuringiensis. It will produce food poisoning. It is also used as larvicidal agent. Mainly it is used for the mosquito control. Next one is the Bacillus used as sterilization control. Bacillus stereothermophilus and Bacillus subtilis both are used for biological controls for autoclave and plasma sterilization. Bacillus pumilus, it is used as biological control for ionizing radiation. Bacillus globigi, it is used for biological control for ethylene oxide. Thank you.